this is a disease like majority of cutaneous malignancies that really deserve to have a multidisciplinary team manage them. Um, so can you talk a little bit about how your multidisciplinary team works at Memorial?
Surely. So, when we are presented with these advanced or metastatic squamous cells, we normally bring this to our multidisciplinary skin cancer management team, and that's comprised of dermatologists, head and neck surgical oncologists, of course, our medical oncologists, radiation oncologists, and plastic surgeons as well, because we want everyone's opinion to see how we best approach this patient and what to use first line, or thinking down the road, what would they need later. So I do think it really helps to get everyone's opinion, because there's nuances, if there's going to be reconstruction associated with the surgery, how will that factor in if the patient gets radiation? Will they heal? Or if we try immunotherapy up front, what are our goals and what are our plans later on? So bringing these patients to a tumor board, I think, is quite helpful, especially because it gives a really nice plan, and the patient knows that a lot of people are thinking about how to best approach this.
Yeah, I agree. My patients actually really get very excited when they know that they are the topic of discussion.
Yeah.
To know that there's a room full of people who are really ping-ponging back and forth about what's the best thing to do in what sequence. So I agree, we do very much the same thing. Now everything's become virtual, so we actually get more participation because everybody can log in and see this. We present the slides, we present pictures, and again, patients are very comforted in knowing so many people gave an opinion without them having to go to those multiple physicians.
Definitely. And I think, they really actually appreciate, the amount of time that goes into each of their individual decisions.
Yeah, I agree. How do you choose between palliative care and hospice or supportive care versus a therapeutic intervention? And I know for me, it really is patient dependent. It's also based on how many comorbidities the patient has, how sick the patient is, and what the extent of the patient's disease is. There, other than immunotherapy, there are other therapeutic options, uh, like chemotherapy, radiation we had talked about for palliation, um, EGFR inhibitors also can be looked at as a way to manage patients. Um, I think there are enough of options that patients can really be offered something other than immunotherapy if that doesn't help. However, if you're talking about a very old patient who is going to become further debilitated because of chemotherapy or because of radiation therapy, then I think it really becomes a very honest talk between the oncologist and the patient as to what is our end goal. Are you looking to buy yourself more time, or are you looking for quality time? Because when it comes to my opinion, I would much rather give people quality time than being miserable for a longer quantity of time. And I think most people are really on that page. So that's when the discussion comes up between palliative care versus with therapy or interventions versus palliative care / supportive therapy. Manage my pain, keep me comfortable, and let me live out whatever time I have left, but in a comfortable manner at home with my family.